welcome our guest speaker, Dr. Karen and Dr. Grace, all discussants and participants to this virtual symposium on challenges in histopathologic diagnosis of Erdheim-Chester disease. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital, Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes as well, like PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Dr. M.B. Agarwal to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Good evening to everybody from India, and good morning to our guest speakers. Today, we have Dr. Karen from Rochester, Minnesota as the guest speaker. And we also have Miss Grace with us from the ECD. Dr. Karen will be speaking on challenges in histopathological diagnosis of EC disease. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and team from Zydus, Mr. Yash, Mr. Kalpesh and team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Karen and Ms. Grace, all our discussants who are themselves eminent hematologists, medical oncologists, or hematopathologists, and you participants for sparing your Saturday morning, afternoon, or evening. Tomorrow morning, that is Sunday, 5th May, at Indian time 11:30 and Singapore time 2 p.m., we have Dr. Nagarajan Chandramoli from Singapore speaking to us on maintenance therapy of multiple myeloma. Discussants, we have plenty of them this evening. I'll just very briefly introduce them to you. Dr. Abhishek Purohit, Jodhpur. Dr. Akshaya Mandaloi, Mumbai. Dr. Amrit Kaur Kaler, Mumbai. Dr. Anandraj Vaithi, Pondicherry. Dr. Anju Bharti, Varanasi. Dr. Ankur Ahuja, Pune. Dr. Arihant Jain, Chandigarh. Dr. Chitra Madiwale, Mumbai. Dr. Debditra Ray from Bangalore. Dr. Deepak MB, Bangalore. Dr. Gopinathan, Chennai. Dr. Nin Mea Thanda from Myanmar. Dr. Soli Sadri from Navsari. Dr. Jyoti Sane from Ahmedabad. Dr. Kunal Chattani from Nagpur. Dr. Kunal Goyal from Mumbai. Dr. Mallikarjun, Bangalore. Dr. Manu Vimla Chandra from Sri Lanka. Dr. Meenakshi Suri from Jammu. Dr. Meenu Angi from Ahmedabad. Dr. Muhammad Tala Ali Khan from Hyderabad. Dr. Mayat Marla Shiv from Myanmar. Dr. Pujita Baireddy from Hyderabad. Dr. Prerna Chaudhary from Jaipur. Dr. Prerna Chautmal from Mumbai. Dr. Pushpanjali Oza from Ranchi. Dr. R. Balasubramanian from Madurai. Colonel Dr. S. Venkatesan from Pune. Dr. Satish Kumar A. from Bangalore. Dr. Savitri Singh from Noida. Dr. Shivani Joshi from Nashik. Dr. Shubhangi Agale from Mumbai. Dr. Tushar Sehgal from Delhi. Dr. Udyan Kachi from Vadodara. Dr. Y. Monthan from Myanmar. To introduce our guest speaker this evening, Dr. Karen. She is Associate Professor of Pathology, Consultant Division of Hematopathology, Department of Lab Medicine and Pathology, Mayo Clinic, Rochester. She received her MD from the University of North Carolina, Chapel Hill, followed by an anatomic clinical pathology residency and fellowship in surgical pathology and hematopathology from Mayo Clinic Graduate School of Medicine. She serves as the vice chair of the Lymphoid Working Group and is a medical director of the immunohistochemistry lab at the Mayo Clinic. Inspired by a busy clinical practice, her research interest focuses on novel diagnostic markers in lymphoma, amyloidosis, and histiocytic dendritic cell neoplasms. Her ongoing research focuses on the characterization of the phenotypic spectrum and genomic landscape of histiocytic dendritic cell neoplasms. She has authored several publications, including practical guidelines for the diagnosis of histiocytic dendritic cell neoplasms and the WHO book chapter on follicular dendritic cell sarcomas. As a key member of the multidisciplinary Mayo Clinic, University of Alabama, Birmingham Histiocytosis Working Group, she seeks to expand medical knowledge and improve the outcome of patients with EC disease, Rosai-Dorfman disease, Langerhans cell histiocytosis, and malignant histiocytosis. Today, she will be lecturing on challenges in the histopathologic diagnosis of ECD. We also have Ms. Grace with us. She has been the Chief Executive Officer of the EC Disease Global Alliance since October 2023. ECDGA is an independent, non-profit organization dedicated to awareness, support, education, and research related to ECD. Her background is an advocate for person and family-centered care with subject matter expertise in family caregiving, long-term care, health policy, aging, and disability. Previously, she had served as the CEO for the National Academy of Elder Law Attorneys, as well as the President and CEO of the National Alliance for Caregiving and the Secretariat for the International Alliance of Care Organizations. Working with Global Genes and colleagues across the rare disease space, she led the first ever policy study of rare disease caregivers, capturing perspectives from 1,400 friends and family members of people living with rare diseases across 400 conditions. She's a frequent public speaker on topics related to caring for older adults and people with disabilities, including keynote addresses at the NIH Office of Rare Diseases and for major media, including the New York Times, the Wall Street Journal, the C-SPAN's Washington Journal, O Magazine, and Women Health, amongst others. Well, I stop here and hand over the platform to Dr. Kiran.
Thank you very much. I really appreciate the kind introduction, and I would like to wish a good morning to all of you, or a good evening there. It's morning for me here in Minnesota. I'm pleased to be speaking with you today on the challenges in the histopathologic diagnosis of Erdheim-Chester disease. This is a topic that I've really been focusing on in the last about 10 years of my career, and it's been a very gratifying journey. Can everybody see my screen?
Yes.
Okay, and everybody can hear me?
Yes.
Thank you so much. So Erdheim-Chester disease is a systemic inflammatory myeloid neoplasm. This has not always been known to be a neoplastic process. It was for a long time thought to be an inflammatory disease of uncertain etiology, more akin to a rheumatologic condition. But with the identification of recurrent mutations in genes, particularly in BRAF, it is now classified as a neoplastic process in the WHO classification of hematolymphoid neoplasms. In this disease, the neoplastic histiocytes accumulate in organs throughout the body, and there's a very characteristic pattern to that organ involvement, which causes the syndrome of ECD. This is a chronic disease and shows very slowly progressive but vague symptoms. So there's often a lag between the presentation of the disease and the definitive diagnosis. Today, we're going to talk about how to make that diagnosis from a pathology perspective. And I'm going to go through various steps to the diagnosis. I think with a disease that is it has such a variety of presentations and very nonspecific presentation that overlaps with a lot of other diseases, it's important to start with the clinical and the radiologic features, which really can raise suspicion for the disease. I'm also going to talk about the differential diagnosis, which differs based on the site, the anatomic site that is involved. Then we'll talk about the histopathologic features, both the histology and immunohistochemistry to phenotype the lesion. We'll talk about mutational analysis and then some additional considerations, including mixed histiocytosis and associated myeloid neoplasms. So starting with the clinical and radiologic suspicion for Erdheim-Chester disease, this is a disease that primarily affects adults, usually in the 40s or the 50s in terms of age. There's a predominance in males over females, and it presents with bone pain, fatigue. It can present with ureteral obstruction, polyuria and polydipsia due to diabetes insipidus, exophthalmos, xanthelasma, especially about the eyes, ataxia, or cough and dyspnea. So very nonspecific symptoms that could occur in a variety of disease states. The most common sites of involvement of Erdheim-Chester disease would be the bones, the long bones in particular, the retroperitoneum, particularly the perirenal space, the aorta, the right atrium along the right atrial groove, the pituitary, the lung, the CNS, particularly the pons and the cerebellum, the skin, and the orbit. An important thing to recognize is that Erdheim-Chester disease does not involve lymph nodes. This is in contrast to other histiocytoses, including Rosai-Dorfman disease and Langerhans cell histiocytosis, which frequently does involve lymph nodes. So if there is lymphadenopathy in the patient, it's unlikely to represent Erdheim-Chester disease, or there is more than one process going on. The finding of symmetric PET-avid osteosclerotic lesions in the distal femora and proximal tibiae are essentially pathognomonic for Erdheim-Chester disease. This occurs in most classic cases of Erdheim-Chester disease and highly raises the suspicion. However, typically a CT scan will only go through mid-thigh. So in a patient where ECD is suspected, it is important to do a PET scan from vertex to toes in order to capture these bony lesions around the knee. In the retroperitoneum, there are very characteristic radiologic findings that are termed hairy kidney. This describes the fat stranding that's seen in the perinephric space due to involvement by ECD. It's very characteristic and very suggestive of ECD. Also, the term coated aorta is used to describe the thickening of the soft tissue around the aorta due to involvement by ECD. This diagram is a depiction from the Mayo Clinic proceedings. This was a publication that resulted from collaboration of our Mayo Clinic histiocytosis working group, which we founded in 2017. And this publication was in 2019, and it illustrates the systemic nature of Erdheim-Chester disease. You can see that it involves a real wide variety of anatomic sites. But as I mentioned, it's a very characteristic distribution. The bones are most frequently involved, 95%. And as I mentioned, the osteosclerotic lesions around the knees are pathognomonic. And you can see that illustrated in the radiograph on the lower right. Also very common is retroperitoneal disease. And you can see an example on the left of the hairy kidney that is seen characteristically in Erdheim-Chester disease. And you can see the other frequent involvement of the CNS, especially in in the posterior fossa. Also, the endocrine system, diabetes insipidus is very common and actually can precede the diagnosis of Erdheim-Chester disease by up to 10 years. The heart is frequently involved along that right atrioventricular groove, and that is a feature that is not seen in other histiocytic neoplasms, including LCH and Rosai-Dorfman disease. So based on this anatomic site of involvement, the differential diagnosis for Erdheim-Chester disease is quite variable. In all anatomic sites, one should consider infectious processes or any reactive or reparative inflammation due to tissue injury or resolving abscess, or if the biopsy is at the peripheral location of another neoplasm, you can have some tissue injury and repair. And so the infiltrate can be very nonspecific and can be difficult to distinguish from reactive infiltrates. Other histiocytic neoplasms also are in the differential diagnosis, including Rosai-Dorfman disease and Langerhans cell histiocytosis. Specifically referring to the retroperitoneum or the perinephric or mesenteric sites of involvement, in this space, the differential includes retroperitoneal fibrosis or sclerosing mesenteritis, which can be very difficult to distinguish. Xanthogranulomatous pyelonephritis, fat necrosis can look very similar. IgG4 related disease can cause a sclerosing process in the retroperitoneum. And then other entities that particularly cause a sclerotic retroperitoneal infiltrate include follicular lymphoma and carcinoid tumor. So these should always be considered when there's a sclerotic infiltrate in this area. In the bone, the differential also includes fibrous dysplasia, which can have an infiltrated foamy histiocytes as well. Osteomyelitis, injury with healing reaction, a vascular lesion also could be a consideration. When the skin is involved, there are other xanthogranulomatous infiltrates that enter the differential diagnosis, including adult or juvenile xanthogranuloma and necrobiotic xanthogranuloma, which is associated with monoclonal gammopathies and is unlikely to be a clonal histiocytic neoplasm. The orbit is a particular site that can be involved by xanthogranulomatous infiltrates in particular. So the differential is broader at this site, including adult xanthogranuloma, also APOX, which stands for adult onset asthma, and periorbital xanthogranuloma, which is a unique presentation in adults and unassociated with systemic Erdheim-Chester disease. Necrobiotic xanthogranuloma, xantholasma, which includes foamy histiocytes, foamy infiltrates that occur more superficially in the skin about the orbit and can be associated with hypercholesterolemia. And IgG4 systemic related disease also frequently involves the orbit. In the CNS, the differential would include infection, inflammatory or demyelinating disease, and also I've seen examples of clippers, of cases of ECD that have been misdiagnosed as clippers before the correct diagnosis of ECD was established. Clippers stands for chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids, which is pretty self-explanatory, but can enter the differential both radiologically and clinically. The characteristic histopathologic features of Erdheim-Chester disease is that of foamy histiocytes, excuse me, and Teuton giant cells. And in the image on the right, we see the classic infiltrate. We see a Teuton giant cell in the center with these peripherally located multiple nuclei in this enlarged multinucleated cell. And then surrounded by foamy histiocytes with this lipidized cytoplasm, small nuclei, which look rather bland, and then intermixed inflammatory cells, including small lymphocytes and occasional granulocytes. So this is the classic appearance. However, you can have a variety of histologic appearances in Erdheim-Chester disease, and the histiocytes can appear scalloped, more vacuolated, spindled, or oncocytic with denser, more eosinophilic cytoplasm. The background typically is inflammatory, but you can have extensive fibrosis in some lesions with minimal cellularity and a sparse lymphoplasmacytic infiltrate. So it can be difficult to identify. And in my experience, it seems that maybe less active lesions, more almost burnt out lesions, have increased fibrosis. And in a single patient, you can have some lesions that are more fibrotic and some lesions that are more cellular and have the typical xanthogranulomatous appearance. This slide shows 4 different cases of Erdheim-Chester disease and the variety of histologic appearances that can be seen. On the top left, we have a mesenteric biopsy, which has kind of an edematous stroma and has these scattered histiocytes that have sort of an epithelioid appearance and a little bit of amphiphilic cytoplasm, a little bit of bluish tint to the cytoplasm. And these were shown to be BRAF mutant cells on IHC, confirming a diagnosis of ECD. On the top right, we have a perinephric biopsy. This was a patient with the typical hairy kidney sign radiologically. And on this example, you can see that the histiocytes are more epithelioid. The nuclei are a little bit more enlarged and a little more irregular. And the cellularity is much denser. And this case was also BRAF V600E mutated. On the lower left, we have a spinal cord lesion. In this, we can see that there is a bit more pleomorphism to the histiocytic infiltrate. The cells, the nuclei are a little bit more enlarged. The chromatin is a little bit more dispersed, a little more irregularity to the histiocytes, and then this inflammatory background. And this case was shown to have a CSF1R, CSF1 receptor genetic alteration that was driving the Erdheim-Chester disease. On the lower right, we have an example of a skin biopsy. And in this case, the histiocytes have abundant cytoplasm with very glassy cytoplasm, very glassy appearance. And we have a multinucleated giant cell here as well. But in general, less of an inflammatory infiltrate in the background. And this case also had a BRAF V600E mutation. So moving beyond the histology to immunohistochemistry, the panel that I would recommend in the workup of Erdheim-Chester disease would be a CD163 and a factor 13A. These 2 markers establish the macrophage phenotype that is characteristic of Erdheim-Chester disease. S100 also should be performed and can be positive in Erdheim-Chester disease, but is also typical of Rosai-Dorfman disease or LCH. CD1A and Langerin are typical of Langerhans cell histiocytosis. And then the last 2 stains on the list, cyclin D1 and BRAF V600E, are to identify the mutation in a subset of cases. And cyclin D1 overexpression can be used as a surrogate marker for MAPK pathway activation. Based on the differential diagnosis, both clinically and histopathologically, additional stains could be considered, to including CD3 and CD20 for lymphoma, IgG and IgG4 for IgG4 related disease, and then AFB and GMS if an infection is considered in the differential diagnosis. This table summarizes the expected phenotype of Erdheim-Chester disease and compares it to that of the other histiocytoses, which can be in the differential diagnosis. And that includes RDD, which is Rosai-Dorfman disease, JXG, which is juvenile xanthogranuloma, ICH, which is indeterminate cell histiocytosis, and LCH, which is Langerhans cell histiocytoses. In all of these histiocytic processes, cyclin D1, shown in the top row, should be positive, as this is a surrogate marker of MAP kinase pathway activation. And this is a pathway that is activated in all of these diseases. CD163 and factor 13A, as I've mentioned, are lineage, indicate a macrophage lineage, which is what you would expect for ECD and JXG, both of those being positive. Rosai-Dorfman disease can show some expression of these, but ICH, indeterminate cell histiocytosis, and Langerhans cell histiocytosis should be negative in general for these macrophage lineage markers. OCT2 and S100 are seen in monocytic processes, and Rosai-Dorfman disease has a monocyte-like phenotype with expression of OCT2 and S100. Erdheim-Chester disease is in general negative for OCT2, but can show partial S100 expression in up to 30% of cases. Juvenile xanthogranuloma has a very similar phenotype to ECD with more frequent expression of OCT2. Indeterminate cell histiocytosis and Langerhans cell histiocytosis in general are negative for OCT2, but can show partial expression. However, S100 is usually expressed in both of these categories. Langerhans cell and myeloid dendritic cell lineages can show expression of ZBTB46, which is a more recently identified marker of myeloid dendritic cell lineage. ICH and LCH both express CD1A. However, LCH expresses Langerhans, whereas ICH is negative for Langerhans expression. All of these dendritic cell markers should be negative in Erdheim-Chester disease. So looking at an example case for immunohistochemistry, this is a skin biopsy from a 61-year-old man who presented with some dizziness and multiple skin lesions. A brain MRI showed lesions in the pons, which was suspicious for a histiocytic process. The skin biopsy shows an infiltrative histiocytes and also some Teuton giant cell-like cells. And we have this abundant cytoplasm, which has kind of a two-toned appearance with some areas more basophilic and some areas more eosinophilic. This is considered consistent with a reticular histiocytoma based on this two-tone appearance in the cytoplasm. CD163 is positive and factor 13A is also expressed, confirming a macrophage lineage for the infiltrate. And a BRAF V600E immunostain using a VE1 clone also shows diffuse positivity within the histiocytes. And so putting everything together with the clinical presentation, as well as the immunohistochemical findings, the diagnosis is established as Erdheim-Chester disease. In cases that have CNS lesions that are suspicious for histiocytic process, a skin lesion often provides a easily biopsied site that may provide the diagnosis and avoid biopsy in the CNS, as was the case here in this patient. This is another example. This is a perinephric biopsy that was taken from a 44-year-old man who presented with cerebellar ataxia and elevated C-reactive protein and had thickening around the aorta, which was concerning for a large vessel vasculitis. Also noted on the imaging was perinephric fat stranding, which was not described as hairy kidney, but has the features of hairy kidney disease, hairy kidney sign. You can see in the H&E section that the infiltrate shows a lot of foamy histiocytes, areas of fibrosis, and a sparse lymphocytic infiltrate. The CD163 shows a lot of staining in the histiocytic process, including the foamy histiocytes. However, factor 13A and the BRAF V600E were not expressed extensively in the foamy histiocyte component, but rather limited to the smaller, more epithelioid histiocytes. This is a common pattern that is observed in Erdheim-Chester disease. It seems that perhaps the foamy histiocytes are not all neoplastic, or they're not actively transcribing the mutant BRAF V600E protein. So in this case, the diagnosis was established as Erdheim-Chester disease, given the overall clinical, radiologic, and pathologic findings. This is another example that was a lung biopsy from a 43-year-old man who presented with shortness of breath, and CT scan showed ground glass opacities throughout the lungs. You can see on the H&E that there is a foamy histiocytic infiltrate that is widening the alveolar septi. And so the possibility of Erdheim-Chester disease was considered. A CD163 stains those cells and identifies them as histiocytes. And the factor 13A stain does show some weak cytoplasmic staining in those cells, which is kind of equivocal. Factor 13A usually shows both nuclear and cytoplasmic staining, and so this was an atypical pattern of expression. A BRAF V600E stain was performed and showed diffuse reactivity within the foamy histiocytic population. And so initially this patient was diagnosed with Erdheim-Chester disease based on these findings. The patient was put on a BRAF inhibitor, vemurafenib, and showed no response. Additional biopsy was performed with similar findings. However, genetics studies to confirm the BRAF V600E mutation were negative. Upon reviewing the case, the hypothesis is that the positivity seen in the histiocytic population is cross-reactivity rather than true BRAF mutation. In the upper right-hand corner of the BRAF V600E stain, you can see the cilia are highlighted by this immunohistochemical stain. And this has been reported that the VE1 clone cross-reacts with proteins in the ciliary axonemes. And so this is a cautionary statement that reactivity does not necessarily correlate with BRAF V600E mutation, and caution should be exercised, particularly when in the lung. I've also seen this in the pituitary, where ependymal cells have some ciliary that can cross-react with the VE1 clone. So the cases that I've shown so far have been positive for BRAF V600E mutation. But what if this immunostain is negative for BRAF V600E? In that situation, the diagnosis of Erdheim-Chester disease is not excluded because although the most common mutation in ECD, it is present in only 50 to 60% of cases. The other cases of Erdheim-Chester disease are largely driven by other mutations in the MAP kinase pathway, most commonly MAP2K1, also KRAS and NRAS, or less common genes in that pathway. The PI3K pathway also can be involved in Erdheim-Chester disease. And at the right in the diagram, you can see the parallel nature of these pathways. They can be activated by similar receptors, and they both result in phosphorylation of either pERK or PAKT, and then result in upregulation of cyclin D1. In other histiocytic neoplasms, including Langerhans cell histiocytosis and Rosai-Dorfman disease, this overexpression of cyclin D1 has been demonstrated by IHC, and it's been shown to have diagnostic utility in distinguishing these infiltrates from reactive histiocytic proliferations. So we ask the question, is IHC for cyclin D1 useful also in the diagnosis of Erdheim-Chester disease? We recently evaluated this in 36 cases of Erdheim-Chester disease and presented these results at the Erdheim-Chester Disease Global Alliance meeting last week or last month in Seattle. Out of 36 tested Erdheim-Chester disease cases, we found overexpression of cyclin D1 in 83% with a very unique staining pattern. These cases showed cyclin D1 positivity not only in the nucleus, as is seen in typical examples of mantle cell lymphoma, but also strong staining in the cytoplasm as well. Of the MAP kinase pathway altered mutations with a confirmed mutation, that percentage went up to 90% with 28 of 31 cases with a MAPK pathway gene alteration, showing this nuclear and cytoplasmic expression of cyclin D1. We had 2 cases in our cohort that did not have a confirmed mutation, but had a clinical diagnosis of Erdheim-Chester disease. And those 2 cases also showed nuclear and cytoplasmic expression of cyclin D1. The cases on the right-hand side, those 4 cases going from top to bottom, are examples of H&E and cyclin D1 staining with this strong nuclear and cytoplasmic expression. The top example is from a perinephric biopsy, which showed a lymphohistiocytic infiltrate. And you can see that the cyclin D1 shows clusters of histiocytes that show strong nuclear and cytoplasmic expression that is even evident on low power. The second case, there is a skin biopsy. This is the skin biopsy that I showed previously with the BRAF V600E mutation. And you can see that the cyclin D1 shows strong nuclear and cytoplasmic overexpression. The third case there is an orbital biopsy in a patient that had bilateral exophthalmos and had xanthogranulomatosis infiltrates on biopsy. And the cyclin D1 shows strong nuclear and cytoplasmic staining in the histiocytic population. This patient also had a BRAF V600E mutation, and unfortunately, the progression of her Erdheim-Chester disease led to total blindness. The fourth case is a lung biopsy in a patient with Erdheim-Chester disease, and you can see that the histiocytes show strong nuclear and cytoplasmic expression. And in this case, there was a MAP2K1 mutation identified. We had 2 cases that we looked at that had mutations in the CSF1R tyrosine kinase receptor. In these 2 cases, cyclin D1 was also overexpressed in the histiocyte population. However, the expression was mostly confined to the nucleus, as you can see on the lower image here, with these scattered histiocytes in the brain parenchyma. This is a brain infiltrate. It's interesting to note the difference between the MAP kinase pathway altered and the CSF1R mutated cases, and this requires further study. It's interesting to hypothesize about the significance of the cytoplasmic staining by cyclin D1 in these neoplasms. Cytoplasmic cyclin D1 has been shown to have different roles when it's present in the nucleus versus the cytoplasm. In the nucleus, it has a role in cell proliferation and cell cycle progression, whereas in the cytoplasm, it's involved in cell adhesion and migration. So this may have a unique role in the pathogenesis of Erdheim-Chester disease. We compared the cyclin D1 expression that we observed in Erdheim-Chester disease with that in reactive histiocytic infiltrates to determine the utility as a diagnostic marker for ECD. Our control cases included examples of entities that can be in the differential diagnosis and can be misdiagnosed as Erdheim-Chester disease, and included idiopathic retroperitoneal fibrosis, cutaneous xanthogranuloma, orbital xanthogranuloma, IgG4-related disease, xanthogranulomatous pyelonephritis, fat necrosis, fibrous dysplasia, and post-chemotherapy histiocytic pseudotumor. In all of these cases, we saw negative to weak nuclear cyclin D1 expression in only scattered histiocytes, in contrast to the strong nuclear and cytoplasmic cyclin D1 expression that we generally saw in Erdheim-Chester disease. And so on the right, there's an example of a case of idiopathic retroperitoneal fibrosis. The CD163 highlights scattered histiocytes in this fibrotic background, a histologic pattern that definitely could represent Erdheim-Chester disease. Factor 13A is also expressed in these cells. However, cyclin D1 is negative in the infiltrate. And so this distinguishes it from a case of Erdheim-Chester disease. In contrast, we also looked at p-ERK staining, as this also is upregulated in MAP kinase pathway activation. This showed diffuse staining in stromal cells as well as histiocytes. And so it was concluded that p-ERK is not as useful in distinguishing ECD from reactive infiltrates compared to cyclin D1. We did see some exceptions in the cutaneous xanthogranuloma cases, of which we had 3. In these cases, we did see strong nuclear cyclin D1 expression, and 1 case that had also cytoplasmic cyclin D1 expression. The cyclin D1 expression was more patchy in these examples of cutaneous xanthogranuloma and more diffuse in ECD. However, it suggests that the MAP kinase pathway is activated in these cases of cutaneous xanthogranuloma as well. And so it may not be useful to distinguish a cutaneous xanthogranuloma from systemic Erdheim-Chester disease. So looking at another example to examine the utility of cyclin D1, we have a 71-year-old man with a history of idiopathic pleural effusions who presented with shortness of breath. A chest CT scan showed diffuse bilateral pleural thickening, as well as some pericardial thickening, and diffuse bilateral irregular intralobular septal thickening more prominent in the lower lungs, with mild ground glass opacities diffusely. On the right, you can see the H&E, and on the lower panel, you can see a factor 13A stain, and you can see that there is thickening of the alveolar septae, as well as marked thickening of the pleura here, and there is diffuse expression of factor 13A within these areas that highlight these thickened septa and the thickened pleura. Focusing on high power at the infiltrate that involved the pleura, we can see that the histiocytes show very plump cells with very dense eosinophilic cytoplasm. CD163 and factor 13A highlights these as a macrophage lineage, and cyclin D1 shows strong nuclear and cytoplasmic overexpression in these histiocytes. Also present is some emperipolesis, which can be seen in Rosai-Dorfman disease and is a characteristic finding, but also can be seen in other histiocytic neoplasms and is not specific for Rosai-Dorfman disease. In this case, immunohistochemistry was negative for BRAF V600E. However, the cyclin D1 staining suggested MAPK pathway activation. So we have an atypical histiocytic infiltrate suspicious for Erdheim-Chester disease based on these findings. And what is the next step? Mutational analysis then becomes important to confirm a diagnosis of Erdheim-Chester disease in this setting. This is indicated when the BRAF V600E IHC is negative, or if it shows equivocal staining, which in which a confident determination of the mutation status cannot be made. The NGS panel should cover genes that are included in the MAPK pathway and also the PI3K pathway, as well as certain tyrosine kinase receptors that have been implicated in the pathogenesis of Erdheim-Chester disease, including CSF1R, ALK, and RET. Most NGS panels will include RNA sequencing, and this is important to detect cases that have gene fusions, including BRAF fusions, ALK fusions, or FGFR. The sensitivity of the genetic testing used is important because the VAF, the variant allele frequency in these cases, is often very low at the range of 3 to 5%. And so sometimes a BRAF mutation or other MAPK gene mutations will be only 3%, but it has been shown in studies that these cases still respond to BRAF or to MEK inhibitors, indicating that this mutation is indeed driving the pathologic process. So in our lung biopsy case, NGS did identify a mutation in MAP2K1. This confirms a diagnosis of Erdheim-Chester disease and also implies that the patient is eligible for a MEK inhibitor, such as cobimetinib. So after the diagnosis of Erdheim-Chester disease is established, there are additional considerations as well. Some cases occur as a mixed histiocytosis in which there is both an Erdheim-Chester disease component as well as a component of another histiocytic neoplasm, either in the same biopsy or at another anatomic site. These include LCH and RDD. So a mixed histiocytosis can be considered if there is an unusual presentation that would not be typical for Erdheim-Chester disease. For example, if there's lymphadenopathy in the patient, that's not typical of Erdheim-Chester disease, but could be typical of RDD and LCH. If the bone lesions are more lytic rather than osteosclerotic, that would be more typical of RDD or LCH, which typically shows more lytic lesions. Testicular involvement is also suggestive of a mixed histiocytosis. When there is a mixed histiocytosis with ECD plus LCH, these are most commonly BRAF V600E mutated. When the combination is ECD plus RDD, these are most commonly KRAS or MAP2K1 mutated because RDD is very uncommonly harbors a BRAF V600E mutation. The testicular involvement that has been seen in some cases is strongly associated with a MAP2K1 mutation, and the testicular infiltrates show features of Rosai-Dorfman disease, whereas other locations show histology consistent with Erdheim-Chester disease. The other consideration that should be considered in patients with Erdheim-Chester disease is that of an associated myeloid neoplasms. CHIP mutations, including those in TET2, ASXL1, and DNMT3A, have been identified in up to 42% of Erdheim-Chester disease patients. And overt myeloid neoplasms, most commonly chronic myelomonocytic leukemia, have been identified in 10 to 15% of Erdheim-Chester disease cases. So if there are any abnormalities in the patient's peripheral blood counts, then a myeloid neoplasm and consideration of bone marrow biopsy is indicated. A few examples of mixed histiocytosis that I have seen in my practice. This is an example of a patient who presented with an abdominal wall mass lesion, really thickened abdominal wall in the subcutaneous tissue. And a KRAS mutation was identified in the perinephric soft tissue, as well as the deeper, I'm going to have to correct myself. This was actually not the abdominal wall lesion. That's the next case I'm going to present. This was actually a patient who had perinephric soft tissue infiltrates and also had lymphadenopathy within the mesentery. And a KRAS mutation was identified in the lesional tissue. And there were distinct histologies in the perinephric tissue compared to the mesenteric lymph nodes. So in the perinephric tissue, we have the xanthogranulomatous infiltrate with histiocytes and also frequent Teuton giant cells. And factor 13A was strongly expressed in this infiltrate, as well as CD163, whereas OCT2 was negative and S100 was negative in this infiltrate. And in contrast, in the mesenteric lymph nodes, the infiltrate shows enlarged histiocytes with abundant cytoplasm and peripolesis with engulfment of small lymphocytes and plasma cells within the cytoplasm. The nuclei are enlarged with dispersed chromatin and small pinpoint nucleoli. And these large histiocytic cells were positive for OCT2. They were negative for factor 13A, and they showed only partial expression of CD163. So this has the histopathology of a Rosai-Dorfman disease, in contrast to the perinephric tissue, which had features of Erdheim-Chester disease. This is the example of a mixed histiocytosis in the patient that presented with marked abdominal wall thickening. And you can see up near the epidermis, we have atypical histiocytes involving the epidermis, forming these Poitier microabscesses with these CD1A positive cells, also expressing BRAF V600E. And these cells were also positive for Langerhans. So this epidermal component is consistent with Langerhans cell histiocytosis. The infiltrate that was in the deep dermis and extending deep into the abdominal wall had a xanthogranulomous appearance with foamy histiocytes abundantly and a sclerotic background. Factor 13A showed expression in these histiocytes in contrast to the superficial histiocytic infiltrates, which were negative for factor 13A. And these histiocytes also expressed BRAF V600E, linking the two processes as clonally related. So this is a mixed histiocytosis, including LCH and ECD. This is a case illustrating a patient who had an associated myeloid neoplasm. This was a 65-year-old man who presented with abdominal pain, nausea, and diarrhea. Imaging showed a retroperitoneal mass surrounding both kidneys, the renal vessels, the aorta, and also sclerosing mesenteritis. Radiology was considered most likely to represent IgG4-related disease, but they also suggested idiopathic retroperitoneal fibrosis or lymphoma could explain the findings. Initially, the pathology biopsy was interpreted as consistent with IgG4-related disease due to the clusters of IgG4 positive cells that were seen throughout the biopsy. However, on second review, a diagnosis of Erdheim-Chester disease was established. On high power on the H&E, you can see a background of fibrosis with scattered histiocytes showing some amphiphilic cytoplasm and small benign appearing nuclei. They're positive for CD163, positive for factor 13A in a very strong pattern, and BRAF V600E mutation was identified by immunohistochemistry. The disease course of this patient over the next 6 to 12 months, he progressed from, he developed a monocytosis, and eventually a bone marrow biopsy was diagnosed as chronic myelomonocytic leukemia. He also developed bone lesions over time, and this included bilateral tibia and femur, as well as pubic bones and clavicle. So these are characteristic findings of Erdheim-Chester disease. In addition, he developed cardiac involvement with a right atrial mass and a pericardial effusion. Sequencing studies comparing the retroperitoneal biopsy originally taken with the bone marrow clot section taken approximately 6 months later show that there is a clonal relationship between the histiocytes in the retroperitoneal biopsy and those in the bone marrow clot, with shared mutations in TET2, NRAS, and KRAS. However, the histiocytes that are involving the retroperitoneum and presenting as Erdheim-Chester disease, there are additional mutations identified in both JAK2 and BRAF V600E. And so, interestingly, this subclone presented as Erdheim-Chester disease systemically, which is clonally related to the myeloid clone in the bone marrow, which presented as CMML. So the diagnosis of Erdheim-Chester disease has come a long way due to the identification of recurrent mutations, which have allowed us to better understand the histopathologic spectrum in these disorders. And importantly, it has also provided therapeutic options which have greatly improved the prognosis for these patients. This includes vemurafenib, which was approved by the FDA in the US for ECD therapy in 2017. Cobimetinib was approved in 2022 for the treatment of ECD, RDD, or LCH. mTOR inhibitors have shown response in PI3KCA mutated LCH, and so also can be considered in ECD cases that have similar mutations. Tyrosine kinase inhibitors have shown response in those cases that have mutations in tyrosine kinase genes. And so there is great hope for the future in the advanced diagnosis and the improved outcome of these patients. I'd like to thank you for your attention today, and I'd like to give acknowledgement and special thanks to all of my colleagues in the Mayo Clinic, University of Alabama, Birmingham Histiocytosis Working Group. We've all learned so much since 2017 about these disorders, and it is very gratifying to be able to help this special population of patients.
Thank you, Dr. Karen, for that beautiful presentation. Very complex subject. You made it so systematic, and it was relatively easy to understand today. Before we go to the QA session, may I request Grace to address us?
Hi, good evening, and thank you so much for having me. Let me see if I can share my screen here. It is a true honor to be with y'all today. And I'll just share, I'm here with my hot cup of tea and just excited to talk to you about Erdheim-Chester disease. And of course, Dr. Reck's presentation was wonderful. And I would like to offer you the perspective from the person who is living with ECD and the people who may be caring for them, their family caregiver, or sometimes called carer. So I'm going to walk through a couple of considerations when we think about that long journey to diagnosis. So just the things I want to talk about today, the first is just who are we at the ECD Global Alliance, and giving you some perspective on that. Describing how patients experience ECD from that person-centered perspective, the barriers that we see to diagnosis and the impact that delay can have on an individual with ECD or their family, as well as how we might overcome some of those barriers. So who is the ECD Global Alliance? We are a global charitable nonprofit organization. We are a non-governmental or NGO organization, and we work closely with people who have ECD, their family, friends, and family carers or caregivers, medical professionals, and researchers who are working in ECD and histiocytosis. We're also a person-centered organization. So our founder, Kathy Brewer, was the caregiver for her husband who died from ECD and was actually diagnosed in the autopsy after he passed away. And she got together with a handful of family caregivers and started this organization really with the idea that we needed to do a better job of serving people who have Erdheim-Chester disease and helping the people around that patient. But we're also a research and learning network. And this is a key component of our organization is we have in the past decade funded over 1.2 million US dollars in new research funding for Erdheim-Chester disease, as well as helping to support some of the research that laid the groundwork for new therapeutics. So we find it important not only to have that sort of heart and soul of the experience of living with ECD, but also to pair that with the evidence and the knowledge building activities that we do as an organization. And just by way of example, this is a list of the research we've funded over the last 14 years. And you can see we've done international grant giving as well as within the United States to a number of physicians and researchers who are trying to find better solutions for people who are living with ECD. So what is the experience like if you have ECD, you know, as the person living with it or as someone who loves and cares for somebody with ECD? On the right-hand side, you'll see we have a sort of a summary graphic that's taken from the consensus guidelines for the treatment and evaluation of ECD. And looking at that, I would encourage you to think about that there is no one size fits all. And that's part of the challenging nature of this condition is it can manifest in any number of different organ systems. From a day-to-day impact, many families notice also the presence of neurodegenerative symptoms, which may mimic other conditions like Alzheimer's or dementia. There's a psychological component where many feel overwhelmed or anxious and may display clinical signs of depression, anxiety, or mood swings, and pain and fatigue, which also, co-occur with many of the types of issues that Dr. Reck talked about in terms of pain in your long bones, issues in your endocrine system, heart issues, respiratory issues, urinary issues, and so forth. I think the biggest thing here, and you probably got the sense from the prior presentation, is there's no magic test for ECD. It's a challenging diagnostic odyssey. First of all, because it's hard to get people to even suspect that what might be happening is, this ultra rare histiocytic neoplasm. Most of us think about Occam's razor and the simplest solution is probably the right one, which means that we're just not primed in general to suspect that it might be an ultra rare disease, and that probably makes sense for many patients. But for those who have ECD, it also means that not only is your physician potentially not aware of the condition, but the fact that it manifests in multiple organ systems means that there's no one clear path to diagnosis. It's not as straightforward as something like breast cancer, where there's a pretty clear path for how it might be identified, diagnosed, and then treated. It also can be expensive depending on the health system in your home nation, in your local province. And that means you may have to go through multiple steps to even find the right diagnosis. You might need clinical observation, you might need pathology support, you might have to get imaging done, and all of that contributes to the complexity of getting to the right diagnosis. There are also institutional barriers to finding the right diagnosis. And what I tried to illustrate here is not exhaustive, but points to the fact that we're working in multiple different disciplines, and those disciplines don't always communicate with each other. In the United States, part of the reason we don't communicate is typically because most of our healthcare is paid for through third-party payers like a health insurance company or the National Health Insurance Company. And typically we bill for services on what's called fee for service. So there's not always an incentive for the oncologist to talk to the hematologist, to talk to the nephrologist, to talk to the primary care doctor. And in a lot of cases, people will end up having to do tests over and over again because those systems may not be connected and communicate with each other. In addition to that, there are some institutional barriers that relate to biases. And I say this without judgment. We all carry biases with us, our own attitudes and beliefs, and it takes time and training to account for that when you're caring for other people. But some things may not occur to us when we're thinking about diagnosis, and particularly with an older population, it may be that people are saying, well, this is an older person, so of course they have pain in their joints, or, of course this is happening. And those type of social and behavioral determinants of health, our language, our culture and religion, the racial and ethnic diversity of the community that we're in, our physical environment, things like access to transportation and pollution, our health, our financial health and economic status, all of that can also make it more difficult to get to the right diagnosis, because we might not be having conversations with providers who are thinking about that ECD or rare disease might be present, especially in an adult patient. I think the other challenge for many people when they're thinking about diagnosis is, as a physician, it's hard to deliver bad news. I mean, you are people too, and it's challenging when you care about your patient to deliver news that someone has a life-altering condition and that there may not be a treatment available. And part of what contributes to that on a global scale is the fact that there is a lack of global treatment standards and drug approvals. So just because there are approved therapies in the United States under the Food and Drug Administration doesn't necessarily mean that other approval or regulatory bodies have approved those same treatments. And so I think that can also be very challenging. And there is perhaps a lack of awareness around the efficacy of certain treatments, and some treatments may not be affordable in all places. And that would be true even within countries, like within the United States. It may not be accessible to everyone, but even globally, the types of treatments are not always available. And that can sometimes make people resistant to pursuing something if they think there's not going to be any hope. And I think it bears mentioning, this is an idea from Rare Diseases International, that just by virtue of being rare, it can be hard to find the right diagnosis and treatment. And this is what, as I'm talking about people suspecting that ECD might be at play, it's difficult to do that just by virtue of the condition being rare. There's often times when people are misdiagnosed, where they get inappropriate treatment, and where the clinical management maybe doesn't meet what might help that particular person. And that's just because you only have so much time in the day and you're trying to help as many people as possible. And that makes it difficult to find time for rare disease. But the reality is that delayed diagnosis has a big impact on individuals and their families and their overall quality of life. This is economic analysis from a United States-based organization called the Every Life Foundation for Rare Disease. And they looked at about 10 different rare disease conditions, and they tracked the difference in your economic challenges between getting an early diagnosis versus a delayed diagnosis. They looked at both pediatrics and adults, and they estimate that on average that it cost in the United States alone $220,000 US, almost $250,000 for a delayed diagnosis. And that's because you're spending money not only on things like trying to find transportation to see a specialist, but also things like missing time at work, not being able to work, having to go to multiple doctors and physicians, having to pay for the wrong treatment. And so you have increased hospitalizations. And in that study, they talked about that the average length of delay to find the proper diagnosis is 6.3 years. 6.3 years is a long time to not know what's going on, especially when we're talking about patients, some of whom may be in their 70s or 80s. And so every minute matters in terms of finding people the right diagnosis. So, what are our solutions? I don't want to just tell you these are the problems and not leave you with something to sort of take forward and think about as you move forward in your day to day. I think the first is to start with the consensus guidelines. This is something that we are so proud of our medical professionals for doing, and that is putting together in a peer-reviewed published report consensus guidelines for Erdheim-Chester disease, both the evaluation of it, the diagnosis of it, and the treatment in the molecular era. And that, I think, is a key starting point is understanding some of this work has already been done. You don't have to start from scratch. There are guidelines about treatment, and it is a global community that work together to create these guidelines. Likewise, we are very honored to have a volunteer network of physicians who participate in our ECD Care Center network. And that is a global network of medical institutions who have agreed to consult or refer people to ECD knowledgeable physicians. So this allows not only a patient to try to find someone closer to them in their global community, but also allows researchers to talk with each other. So if you and clinicians to talk with each other. So if you have a patient and you've got a question about them, that you could find another physician with a similar background who can help talk you through some of these issues. And you can actually join our network for free, which will help you be connected in with our events, with our opportunities to talk to each other. And I've included some of that here. We also try to aggregate a digital library of medical resources, of information on ECD studies and trials, as well as how to manage things like paying for care or what to look for if you're in certain specialties. So I would say that we have made a lot of progress, and just the fact that you're here spending your evening with us is something that brings me hope and excitement, because I know that it takes time out of your precious time with your family, with your life, to come and learn about ECD, and we are incredibly thankful for that. So thank you very much, and I appreciate the opportunity to be here.
Thank you. Once again, wonderful. Putting things in its perspective and exposing us to the difficulties which you have assembled so beautifully. Let's open up some discussion. So we have a raise hand sign. Please use that. You can also open your videos so that it can be very interactive. We'll also take questions from the audience. You can put it up in the chat box. We begin with Dr. Ankur.
Good evening, sir. First of all, thank you for inviting me as a discussant. It's a great opportunity to hear about the rare disease, sir. Actually, I also included one of the scenario which Dr. Karan has mentioned. So, ma'am, how common are the scenarios wherein IC for the BRAF 600 are negative and the genetics comes positive? And what could be the reasons behind that? Are there any special precautions we have to use for the IC procedure?
Sorry, I was having trouble unmuting myself. So if I understand your question, you're asking about the IHC for BRAF V600E, and if it's negative, it doesn't have a negative predictive value. Does it have a high negative predictive value? Are there cases where it's negative, but then you find the BRAF mutation by genetic studies? Is that your question?
Yes, ma'am. And when the genetics comes to positive, ma'am.
Yes. So, yeah, that's a good question. In my experience, generally, it has a good negative predictive value. However, I've seen I've seen two case. No, I've seen only one case where the IHC was negative, and then NGS showed the mutation, showed the BRAF V600E mutation, which was a surprise to me. And in that case, it was a patient that had a retroperitoneal fibrosing process, and so clinically they were considering Erdheim-Chester disease, and the histiocytic infiltrate was really sparse because of the fibrosis, and the histiocytes were negative both for cyclin D1 and for BRAF V600E. And so I signed it out as unlikely to be ECD. Additional clinical workup didn't reveal any other possible diagnosis, and so we did send that for next generation sequencing, and then a BRAF V600E mutation was found, and the variant allele frequency was about 3%. So it was confirmed to be ECD. So I think that a negative BRAF stain doesn't have 100% negative predictive value, but I think it's pretty good. And I can only hypothesize about why that's the case, but it seems to be that in more advanced lesions, which are more fibrotic and less active, perhaps there is not ongoing expression of BRAF, of the mutant BRAF gene. Perhaps the cells are more quiescent, and so it's not being overexpressed, and therefore it's not leading to overexpression of cyclin D1. So both of those are negative, but the cells do harbor the mutation. They're just not actively transcribing the gene. So I think in general it has a pretty good negative predictive value, but there are rare cases where you may find a mutation.
And second question, do we have an internal control of BRAF 600E in IHC, especially in the bone marrow biopsy? Because we don't know whether it has worked it or not, ma'am.
Yeah, the answer is no. So the VE1 clone is specific for the mutant peptide, and so it should not stain any normal cells, with the exception of the cross-reactivity of the cilia. So So it is important to have an on-slide QC, because otherwise you really don't know if the test has worked or not. There's no internal control. It's also a stain that we've struggled with, because in order to get the sensitivity, we amplify the signal. We use Ventana platform. And so we have a Ventana Ultra, and we use the OptiView detection with amplification, OptiView plus amp. And so it amplifies the signal, and that tends to increase the background. You can get some granular cytoplasmic non-specific staining, which is difficult. And so optimizing the stain is very important, in order to minimize the background as much as possible. And also you need to have a high threshold for calling it positive. If you think it's equivocal at all, if you think it could be background staining, then it's important to confirm it with genetic testing. If you're just wanting to rule out a BRAF V600E mutation, you could just do a digital droplet PCR for just the BRAF V600. We do that sometimes. But if you have concern that it's a mutation in another MAP kinase pathway gene, then it makes more sense just to go to the broader NGS panel.
Thank you, ma'am. Thanks a lot.
Thank you, Dr.
It was a wonderful lecture.
Thank you.
Thank you.
Dr. Arihant.
Hello, good evening. So thank you for the talk. First question is, am I audible, sir?
You're audible.
Yeah.
Yes.
So one question is that basically this is more for all histiocytic disorders. So our country is kind of a TB endemic country, and we do occasionally encounter particularly the retroperitoneal fibrosis, where it's kind of due to tuberculosis per se. And again, a lot of times the histopathologist may report lymph nodes, particularly in the RDD spectrum, sometimes as granulomatous inflammation, and people tend to confuse it with tuberculosis. So do you think that there are certain, so for a clinician like me, so and to our pathology colleagues as well, do these things can be confused, and what would be the, except for the routine morphology things, are there any things how we can differentiate? That's one question number one.
Yeah, sure. So yeah, I think infectious processes definitely can mimic ECD. You know, here in the Midwest, histoplasmosis is more endemic, and so that histoplasmosis can lead to either sclerosing mediastinitis or sclerosing mesenteritis or retroperitoneal fibrosis. And so we've seen cases like that that mimic ECD. And sometimes the fibrosis is so extensive that multiple biopsies are required before you identify the granulomas with the organisms. So I think it's, you know, definitely important to keep that in mind. You know, I think, you know, tuberculosis generally will have necrotizing granulomas. ECD usually does not have true granulomas. They're not well formed. The histiocytic infiltrate is more diffuse, more interspersed, and not forming clusters with well formed granulomas. So if the histology truly shows granulomas, then I think that would lean you to be thinking infection more than thinking ECD. And if there's any necrosis, that also would strongly favor infection. ECD doesn't show necrosis generally.
Thank you. So the other kind of very interesting notion which you were alluding to were the presence of chip mutations in the kind of molecular landscape of these disorders. So do you think one is peripheral blood an adequate sample to kind of pick? So are these mutations pickable in the blood as well? And do you think we should be, it's just maybe as a part of research, we should be starting to screen all our histiocytic disorders for the presence of these chip mutations, and what's the data currently on that?
Yeah, that is an area that is being actively investigated. So yes, I think that in patients, it's recommended by the current guidelines that patients with ECD, if they have any CBC abnormalities, they should have a bone marrow biopsy to rule out a myeloid neoplasm. I think, you know, if you look for chip mutations in the peripheral blood, that's one piece of information, but you don't really know what that means unless you have a bone marrow biopsy to correlate it with. So we do know that they're more frequent. Chip mutations are more frequent in ECD compared to the general population. And we do know that myeloid neoplasms are also more common. So I think it's a clinical decision, case by case, on whether you get a bone marrow biopsy to rule that out. But definitely it's an area of ongoing research to determine what is the significance for this patient population. I don't think that they need more screening than, than the general population.
And one last question. So regarding the mutational landscape again, so sometimes it becomes challenging on the tissue specimens to kind of get the mutations done. So is there any evidence, or maybe the circulating ctDNA like we talk about in other heme malignancies, or do you think the ERK or the MAP pathway mutations can they be picked up in the peripheral blood as well, and or it's again to be remains to be investigated?
Yeah, that's been looked at as well. In patients with Langerhans cell histiocytosis, particularly the pediatric population, if they have a BRAF V600E mutation in the LCH lesions, then they frequently have it detectable in the cell-free DNA in the blood as well. In adult ECD, it's possible to detect it in the peripheral blood, but it's less common. It's pretty uncommon actually. So in a patient that you're suspecting ECD and a tissue biopsy is inadequate for genetic testing, or for example, if the patient has CNS lesions and it's too risky to biopsy the brain, or you want to try to avoid a brain biopsy, you can do, I think cell-free DNA is a very reasonable approach, because if it is detected, then it puts the picture together, and you can maybe treat them on the clinical picture rather than getting it confirmed on a tissue biopsy. But if it's negative, it doesn't exclude the possibility that there's a BRAF V600 mutation in the tissue, because it usually is not cell-free, is not positive in cell-free DNA in adult ECD patients in our experience.
And one last question. So have we looked at the cytokine profile of these like the various things, because we have a lot of targeted kind of drugs which we tend to kind of borrow from our rheumatology colleagues. And so one is the mutational profile. What is the cytokine profile? Is there any information on that?
Yeah, that's not my area of expertise. In my interactions with my clinical colleagues, we have not used any cytokine-directed therapies. I'm sure it's been looked at, but that would be a better question for one of my clinical colleagues.
Thank you.
Thank you, Arihan. We have a question from the audience. There's a question from Myanmar. Is there any particular histological feature that can predict ECD when we see Toton giant cells in histology?
Yeah, so Toton giant cells, when there's Toton giant cells present in a histiocytic background, then that's the definition of a xanthogranulomatous infiltrate. And so there's a variety of things that can be. So you can have isolated cutaneous xanthogranulomas, both in children and adults. You can have xanthogranulomas pyelonephritis. In the orbit, you can have a number of xanthogranulomatous lesions that we talked about that are associated with other conditions, particularly asthma, or with MGUS in terms of necrobiotic xanthogranuloma. So it's important to put it in the clinical context in terms of which anatomic site it's involving and what are the other findings in the patient. So in terms of histologic features, you can't really distinguish between those other entities. They all look like xanthogranuloma family lesions, and they will all be positive for CD163, for factor 13A, and it seems that probably there's some activation of the MAPK pathway. So you'll see probably some overexpression of cyclin D1 in these lesions. They may not all be driven by a genetic alteration. In the isolated lesions, it may be some physiologic activation of MAP kinase pathway that's causing this histology, but is not associated with a mutation and is not associated with systemic disease. So the answer, is there a particular histologic feature to predict predict ECD? The answer is no. So you have to look at the other features to see whether, what anatomic sites are involved, what are the other clinical findings in the patient, the radiologic findings, and then genetic testing if that's appropriate.
Thank you, Dr. Karen, and thanks for that question. Dr. Chitra, a question. And meanwhile, I also request the faculty here and the audience, if you have an interacting question for Grace. Yeah, go ahead, Dr. Chitra.
Thank you. Both the presentations were excellent and very illuminating. I found the case that was initially diagnosed as IgG4 related disease and then on review diagnosed as Erdheim-Chester very interesting. So what caused the confusion and what would be the key features to avoid barking up the wrong tree? Because when I saw that histology, I thought, I would have diagnosed this as IgG4 related.
Yes, yes, and that's why we're trying to raise awareness for the histologic mimics of this disease, because I think when I trained as a resident and a fellow here at Mayo Clinic, I think I saw maybe 2 cases of Erdheim-Chester disease involving the bone during that time period. And now that I'm much more aware of both the histologic and the clinical findings, I see it several times a week. I mean, a histiocytic neoplasm several times a week. Part of that, of course, is because we have a focused clinic here. But I see it in my consult practice also, which is a general consult practice. So thinking back, I think that we have missed the diagnosis very frequent. I think we've missed the diagnosis more frequently than we have accurately diagnosed the lesion. So, and I see that, I still see that because the case that was misdiagnosed as IgG4 related disease, that misdiagnosis was made by an anatomic pathologist here at Mayo Clinic. So a pathologist who's 3 floors up from me. So we're trying to increase the awareness, in particular in settings where it's frequently misdiagnosed or overlooked, and that involves that includes the retroperitoneum, includes the orbit, includes the heart, around the kidney, the mesentery. We just had a case a couple of weeks ago where a patient came in and had some infiltrates in the mesentery, and the initial impression from anatomic pathology was that it was fat necrosis and reactive histiocytic infiltrates. And then the clinician requested a second review in hematopathology, and it turned out it was BRAF mutant ECD. So this continues to happen, and so we just have to, you have to have an awareness of the settings where it could be misdiagnosed, and correlate with your clinical colleagues and with the radiology, because it takes everyone in the whole team to get to the right diagnosis. I think no individual can get to it on their own. So that's the challenge, I think, in improving the diagnosis for this disease.
Thank you so much. Thank you.
Thank you, Dr. Chitra. Dr. Meeno.
Hello. My question is, like, these cases are showing cyclin D1 expression on IHC. So is there any role of fluorescence in situ hybridization or NGS to check for CCND1 gene rearrangement or fusions?
Yeah, so the cyclin D1 overexpression is related to the activation of the MAP kinase pathway. So the mutations in BRAF or MAP2K1 or the other genes, they're gain of function mutations. So that means that it activates, constitutively activates the pathway, and downstream it drives overexpression of cyclin D1. So the mechanism is based on activation of the pathway rather than a translocation involving CCND1, as is true in mantle cell lymphoma. So it's a different mechanism, and it's the same analogous situation in hairy cell leukemia. Hairy cell leukemia frequently has a BRAF V600E mutation as well, and it also shows overexpression of cyclin D1 for the same reason, but there aren't any CCND1 translocations.
Okay, thank you.
Thank you, Dr. Minu. Dr. Pushpanjali.
Am I audible, sir?
Yes, now you're audible.
Okay. Thank you, ma'am, for such a nice presentation. My question is, ma'am, for how come we would differentiate between reactive histiocytosis with ECD on IHC?
I'm sorry. So can you repeat your question?
Reactive histiocytosis, ma'am, with reactive histiocytosis with Erdheim-Chester disease.
Yeah. So it's a very difficult distinction because the findings in ECD are fairly nonspecific. The atypia in the histiocytes is not pronounced, and so it's a very difficult differential diagnosis. And so I think it's important to start with what clinical suspicion there is, and what is the disease distribution. And then that's important in order to identify cases that already have a high probability of being ECD. And then IHC can be difficult, but if there is overexpression of cyclin D1 in the histiocytic population, then that would favor ECD, particularly if there's strong cytoplasmic staining. In the reactive histiocytic infiltrates, there usually is not cyclin D1 positivity, or if there is, it's very scant, it's very weak in a subset of cells, rather than staining the whole atypical histiocytic population with strong cytoplasmic expression. So the pattern of cyclin D1 expression can contribute to your level of suspicion for ECD.
Thank you, ma'am. And my second question is, ma'am, is factor 13A is necessary to put into ISC panel for Erdheim-Chester disease diagnostic, or there is some another alternative for this particular ISC?
Yeah, so I think, factor 13A is commonly overexpressed in Erdheim-Chester disease, but it's not specific for it. And so it's not required, I don't think, in a panel for diagnosing ECD. I think a CD163 shows the histiocytic infiltrate and shows the extent of the infiltrate. So I think that would be adequate, and a factor 13A is not necessary. People ask me about CD68, which is a more traditional histiocytic marker. And while it's true that it is positive in Erdheim-Chester disease, it's more nonspecific than CD163. It stains not only macrophage but also dendritic cells, and then also it's known to be expressed in others. It can be expressed in melanoma, for example, and so it's difficult. It's not as lineage specific. I think it's also more difficult to interpret because it has more of a granular cytoplasmic staining, whereas CD163 more of a diffuse cytoplasmic staining. So you can identify better which cells are positive, which nuclei are associated with the cytoplasmic staining. So I prefer CD163, but a CD68 is also an option to use for that. And importantly, I think cyclin D1 and then having a good BRAF V600E stain is important as well.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Pushpanjali. We have a question from the clinical hematologist now, Dr. Amit Khurana.
Thank you, sir. And thank you, ma'am, for the wonderful talk. My question is just in continuation with what Dr. Chitra madam had asked. This is regarding the case of retroperitoneal fibrosis. If on retroperitoneal fibrosis, our first impression is always IgG4 disease. And after ruling out IgG4 disease, we are finding out clusters of histiocytes, and immunohistochemistry fails to identify anything of ECD. Do we still need to dig into the matter that this is really ECD with cyclin D1 mutation as well as a BRAF mutation in every case of retroperitoneal fibrosis?
Okay, I apologize. I'm having a little trouble hearing you. The question is, can you repeat the
question? If the patient has
question?
got retroperitoneal fibrosis,
Yep.
our first impression is always IgG4 disease. If it is not IgG4 disease, and on histology, we are finding out clusters of histiocytic cells plus giant cells, is it worth that we always rule out Erdheim-Chester disease in such cases, every case? If,
I see.
and if the histiocytes are not staining positive with CD163, do we need to check for cyclin D1 in all such cases, as well as with BRAF mutation for all such cases?
Okay, so yeah, so if you have retroperitoneal fibrosis, it's important to consider all the possibilities of what could be causing that. So IgG4 related disease is obviously a possibility. Infection is also a possibility. Idiopathic retroperitoneal fibrosis is a possibility. Follicular lymphoma, carcinoid tumor, other things that can cause fibrosis in the retroperitoneum. So Erdheim-Chester disease shouldn't be overlooked, but I don't, not every case is going to be obviously as suspicious as the next. So I think clinical correlation is really important, the radiologic findings. So does the retroperitoneal fibrosis, is it accentuated around the kidneys? Is there perinephric accentuation? Is there fat stranding? Those features suggest Erdheim-Chester disease because that characteristic, is it coating the aorta? That would also favor ECD. And so these findings are what raise your suspicion for ECD in that setting. If you do a CD163 and there aren't any histiocytes, then I think it's not ECD. You should see some histiocytes there. So I don't think every case needs to be explored beyond CD163 if there's not a high clinical suspicion and if there aren't very many histiocytes. I think that if there's any clinical suspicion at all, I think you should do a cyclin D1 and a BRAF V600E.
Thank you, ma'am.
Thank you, Amit, for that question. We had a very exciting discussion between Dr. Karen and Indian colleagues. Many of them are on the diagnostic side, so they had their difficulties, which you sorted out. Regarding Grace, I must say that we are missing similar kind of group on this side. So people probably didn't feel very confident in interacting with you. They didn't have questions for you because we just don't have this kind of group here looking after the rare diseases, which is the need of the hour. But I'm sure the address you gave today will stimulate some people to form this group or approach you. They might be feeling shy today because nothing exists here, but they would approach you and probably you'll be able to help them out. We had a great evening on this side learning about this rare disease. And for the official vote of thanks, we hand over to Zydus, Mr. Sumit.
Thank you, Dr. Karen and Ms. Grace, for sparing your valuable time. It was an excellent presentation and followed by a great discussion and interactive session. We have many key takeaways from this wonderful discussion and presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic platform. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everybody, and have a wonderful weekend.
Thank you, Mr. Sumit, for supporting us. I understand that the International Histiocytosis Society is coming to India. There is a conference in Goa in November, and I'm sure Dr. Karen and Grace both will be here. And I also invite all of you to take utility of that conference, which is in November first week in Goa. So that's all for tonight. Thank you very much. And grateful to both Grace and Dr. Karen. Bye-bye.
Thank you, sir. Thank you all.